Good day. My name is Jennifer Larsen. I'm a professor at University of Nebraska Medical Center in the Division of Endocrinology, Diabetes Endocrinology and Metabolism. And my two-part lecture will be about diabetes and risk for infections. The second part will be particularly focused on COVID-19. My objectives are to review how and why infections are more common or more serious in people with diabetes, discuss how and why diabetes impacts risk or outcomes with COVID-19, and what is available to prevent infections in people with diabetes. And because I work in research, I will be concentrating on some of the things we don't know as well as some of the things that we do, because it's important for everyone to understand there's lots of things that we need to know more about. Diabetes and infectious diseases have gone together for a long time, and historically, in the past, led to a lot of deaths. In the 1920s, 1 of 5 people with diabetes died of infectious diseases. Part of that is because insulin wasn't even available until 1922. Fast forward to the 1960s, and that's improved a lot. Less than 1 in 20 of people with diabetes died of infections. In part, that is because we have better care. We have both more medications for diabetes, but a lot of new antibiotics too, and of course, vaccinations. But diabetes continues to contribute to risk for many infectious diseases, and that's what we're going to explore today. I think it's helpful to start out and make sure that everyone understands the diagnosis and types of diabetes. Diagnosis of diabetes is defined by the American Diabetes Association as meeting one of these criteria: fasting glucose of 126 milligrams per deciliter on more than one occasion, a hemoglobin A1C, which is a 3-month average of blood sugars of 6.5%, and that has to be repeated as well, or a random blood sugar over 200 with all the symptoms of diabetes: increased thirst, increased urine output, blurry vision, weight loss, or to do an oral glucose tolerance test where you drink a sugary substance and 2 hours after you start, the blood sugar is over 200. There are 2 main types of diabetes. We call them type 1 and type 2. Type 1 is caused by an immune destruction due to probably a genetic risk, but stimulated by something in the environment, we think usually a virus. Autoimmune diseases run in families, but skips generations. So it is possible to have other members with type 1 diabetes in your family, but it's more common that there might be someone with other kinds of autoimmune disease in your family. Usually the age of onset is in the younger ages, from the teens and 20s, 30s, even 40s, but there even are people with new onset type 1 diabetes identified in their 80s. The treatment requires insulin. If you don't have insulin, one would develop ketoacidosis, a buildup of acid in the blood, which is fatal if not treated. And that is what happened in the past when we did not have insulin. Type 2 diabetes is far more common. It's a genetic form of resistance to insulin, worsened by excess weight, and it causes the pancreas in the end to stop making insulin. The age of onset used to be 40 years and older, but now we're seeing it in much earlier ages, and in some tribes as early as 5 to 12 years of age. The treatment involves weight loss, changes in diet, in some cases insulin, but many other medications are also prescribed, often before insulin, to decrease the insulin resistance or to help the pancreas make more insulin. There are some other types of diabetes. Some medications cause diabetes, like steroids. Cystic fibrosis is a genetic cause of lung disease that can also cause diabetes. And if the pancreas is injured or lost because of pancreatitis or surgery or from alcohol, you can also develop diabetes. The consequences of diabetes are far-ranging: change in vision, loss of kidney to the point of needing dialysis or transplant, nerve disease causing numbness in the feet, heart disease referring or resulting in heart attacks, and infections, as we're talking about today. The types of diabetes that a person has does impact what kinds of infectious diseases you might be susceptible to. Because many of the people with type 1 diabetes are younger at diagnosis, there is a broader range of people with type 1 diabetes. Type 2 diabetes is generally older at diagnosis, so we're mostly talking about people who are older, and so the infectious diseases that occur in people who are older are more likely as well. We talked about how body mass index is increased in type 2 diabetes in most, if not all, and so some of the conditions that are affected by body mass index will also be greater in this group. In the case of immune considerations, because type 1 diabetes is an autoimmune disease, there are some alterations in their immune functions. But in type 2 diabetes, there's also a very broad environment of inflammation by itself, which may affect their risk for infectious diseases. Heart disease and kidney disease occurs over time in type 1 diabetes. It depends on their age then and what their blood sugar control has been and how long they've had type 1 diabetes. However, in type 2 diabetes, we find that many people have heart disease or kidney disease even before diabetes has started. And so they have those as cofactors as well. All of the individuals with type 1 diabetes are treated with insulin. In type 2 diabetes, they might have many different agents and they have different actions, and they may impact risk of infectious diseases too. Diabetes increases many types of infections. Some of the most common are in the skin, the nails, and the mucous membranes, like gum disease. The anaerobic bacteria of the mouth can cause this. Yeast infections in the mouth, the skin, the vagina, and the foreskin. The Candida species, a kind of yeast, is the most common. Fungal infections can occur in the fingernails and toenails, the scalp, the skin, and on the feet. Usually that's a Tinea species. And very deep bacterial infections of the skin can occur coming in from wounds, or cellulitis, which is just an infection in the skin. You can even see it as an infection of the outer ear, and this is very specific to diabetes. It's called malignant otitis externa. Painful, red, swollen, pus coming out. It's caused by a Pseudomonas species, which is a particularly hard species to get rid of once it gets in the skin. And as I mentioned, it's unique to diabetes. Some of the other kinds of infections, as we talked about, gum disease is pretty common. Wound infections, and here you can see that it's sort of been there a long time. It's having a hard time healing over. It requires a lot of care to make a difference. Yeast infection of the skin usually occurs in body folds, so that's much more likely to occur, as you can see in this upper panel, in people who are overweight and have a lot of body folds. The fungal infection of the nails, here you can see where they're thickened and yellowed, can occur by itself, or you can see the scaly kinds of changes in the skin with a little bit of redness to it that suggest fungal infection in the skin of the feet in this person as well. In fact, the foot is so common for many different kinds of infections in diabetes that we sometimes call it the diabetic foot and write about how to improve the infections of the diabetic foot. And that is because in diabetes you can have nerve injuries we talked about, and if there's numbness in the feet, you don't realize that you've had an injury. So once you break open the skin, that risk of infection begins. Vascular disease, including to the legs, in the legs to the feet, mean that they might be not only more easily injured because the skin is thinner, but also more slow to repair, which allows more time for infection to get started. Swelling of the feet, which occurs particularly with obesity and with heart failure, which can occur with diabetes too, makes injuries easier and slows repair as well. And high blood sugar, of course, is one of the reasons why people with diabetes have infectious diseases, and that is one of the contributing factors in the feet as well. Examining the foot alone by the person who has diabetes or by a healthcare professional can reduce amputations by 50%. That's huge. That means what you're looking for is looking for the nerve injury, the vascular disease, swelling, to see if you can do something about it, making sure is there a break in the skin that needs care, and making sure that the person is wearing shoes to protect their feet, as well as making sure that the shoes fit so that they protect their feet as well. What other kinds of infections are people with diabetes at risk for? Osteomyelitis is an infection in the bone, and that occurs in people with infections in the feet, so it goes from the skin into the bone, and once it's in the bone, it makes it much harder to get any antibiotics to be able to take it back out. And so it is one of the most common causes of amputation with foot infection. Bladder infections, or what we call urinary tract infections, which can go into the kidneys, are also more common, and particularly in women than men, just as regular bladder infections in non-diabetic individuals are as well. And lung infections from many different causes. One of the most commonly historically was tuberculosis. This is caused by a mycobacteria. Bacterial pneumonias of all kinds are more common in people with diabetes, and viral pneumonias from influenza, what we call flu, as well as SARS-CoV-2, which is the virus that causes COVID-19. This shows two chest x-rays. The one on the left shows infection in the lung. The one on the right is a normal person's lung, so you can compare. You can see how sharp the borders are, how easy it is to see the air in the lungs on the one on the right, and on the one on the left, you can see that there's pockets and different what we call opacification, that it's not as easy to see the air, and that is because of lung space disease, lung disease. Now, this could be a lot of different things, but it turns out this is tuberculosis. And as mentioned, this is much more common in people with diabetes than non-diabetes. In fact, tuberculosis has been a concern in tribes for generations. You can see this is a publication from 2005 that shows what the progression of tuberculosis frequency in many different ethnic groups. And in general, you can see that all ethnic groups appear to be reducing overall rates of tuberculosis, which is a good thing. The concern, as you can see here, even though the non-Hispanic blacks had the highest back in 1993 and are coming down the most sharply, that the American Indian, Alaska Native in these triangles or these diamonds actually went up from 93 to 94, and although it's coming down much more shallowly, and in fact in many states the only tuberculosis that is reported in their state is in different tribes. So it continues to be a concern in many tribes. So what kinds of factors drive bad outcomes when people with diabetes get any infectious disease? Older age, particularly for lung infections. Older people are more vulnerable to lung infections and are more likely to die from lung infections. Obesity matters in lung infections because just when you're overweight, it's kind of like carrying a backpack that it's harder to breathe even without the lung infection. And then if you have to breathe with lung infection, it's even harder. Also with obesity, skin and foot infections are more common because of the body folds and the swelling of the feet in particular, as we talked about. Heart and vascular disease is one of the factors that make it harder or worse outcomes for all infections, but particularly lung infections, because again, it just makes a person more vulnerable if the oxygen level drops to have a heart attack. It's also, if you have more vascular disease, as we talked about, that makes a difference in terms of foot and leg infections too. And high blood sugars makes a difference for all kinds of infections. Some other kinds of things that we're looking at that may also be a contributing factor is low vitamin D. We know that people with low vitamin D have more infections over the year of all kinds. And low vitamin D is more common in people who have obesity and in people with darker skin, because the darker skin actually screens out the vitamin D from the sun. In addition, we are using more sunscreen, which is another reason for having a low vitamin D. And if you live at a higher latitude in the world, like the Alaska natives, they have low vitamin D just because they have less sun in many seasons of the year, or in the winter seasons at least. The microbiome is what bugs are in your gut. And it turns out that the microbiome changes with diabetes and changes in a way that the different bugs might make it easier, in particular for viruses, to invade. And so that's something people are looking at as well. As we talked about, we know that our immune system doesn't work quite as well if we have obesity or high blood sugars or both. And some of the diabetes medications can make a difference in a good way and some in a worse way. Insulin makes all infections better. So if people need to be on insulin, being on insulin is a good thing. There's one type of a pill called an SGLT2 inhibitor, a newer diabetes medication that improves blood sugar by increasing the amount of sugar that goes through the kidneys into the urine. And as a result, you have a higher risk of having bladder infections. So that is one that perhaps isn't so good for the infectious disease part. What infections are reduced with better blood sugar? Almost all of them. Certainly we have good evidence for foot infections, surgical wound infections, any infections acquired in the hospital, and community-acquired pneumonias or lung infections. We, in fact, have set goals for what the blood sugar should be in the hospital from 100 to 180 milligrams per deciliter, because we know that white cell functions do better in that range, and everything else does better as well. So why is blood sugar control important? The main reason is because glucose changes immune responses. High blood sugar reduces the white cell's ability to fight infections, and this has been studied in test tubes as well as in animals and from people. It decreases the ability of the white cells to get to the infection. We call that chemotaxis, and superoxide production by the white cells, which is kind of the chemical way that the white cells have of killing the bacteria once it's eaten it up. Some believe that it decreases phagocytosis, which is the term of gobbling up the bacteria. Some think less so, but that may be another contributing factor. And we know that when the glucose is high, it attaches to almost all proteins. In fact, that's how we measure hemoglobin A1C, is actually glycosylated hemoglobin. In the case of the immune system, glycosylation of the IgG or immunoglobulin G antibodies makes them less effective. So that's one of the ways that our system normally would be able to protect us from new invading bacteria. Again, these white cell functions essentially revert to normal if the sugar is less than 180 milligrams per deciliter. So that's the importance of keeping good blood sugar control in the hospital, but also out of the hospital as well. And there's now evidence that insulin improves the white cell functions, whether you have diabetes or not, and regardless of what your blood sugar is. So insulin itself is a value for people who have infections, and particularly in the hospital. What about obesity and type 2 diabetes? Well, it turns out that both obesity, even before type 2 diabetes, increases inflammation markers in the blood and even in the abdominal fat. The results are some of these of changing the type and amount of different lymphocyte T cells, a T population of lymphocytes, by changing the hormones from the fat of leptin, increasing those, and decreasing adiponectin, also normally made in the blood and the fat, in a way that promotes inflammation and increases something called cytokines, C-reactive protein, IL-6, tumor necrosis factor. And it turns out these cytokines themselves cause insulin resistance, and so make blood sugars higher in people who already have diabetes, and make them even higher still if they are sick or stressed in the hospital. Cytokines also reduce the normal immune responses even when someone is not sick. So having more cytokines is not a value. Diabetes also has special impact on lung disease. high blood sugars, and this has been studied again in laboratories as well as in people, increases the amount of sugar in airway secretion, so like in the things that come out when you cough. And that means that sugar, we believe, increases the rate at which viruses replicate or divide and grow in lung cells. So this is a particular disadvantage for lung infections. Long term, it also changes the character of the lung, which is normally allows or is a barrier, if you will, to infection, but it appears to change it in a way that it's more permeable, so infection is more likely. This is mostly in animal studies to date. Plus, obesity restricts lung functions. If someone is obese, you can time and see that their resting and their exercise breathing rates are higher than someone who is not, and their lung capacity and their breathing volume is lower. As you can see on this slide, on the left, someone who's thin, on the right, someone who's obese. What you can see is that that green portion, what we call the expiratory reserve volume, is smaller, and a person has to breathe more rapidly, as you can see by the jagged lines here, just to keep up with someone who has normal lung function, who is leaner. As a result, just to do any kind of activity. You can also see that there are some long-term effects on the airways, and they have a smaller diameter, so they have to exchange air more rapidly to get the oxygen in that they need. Other things we do to prevent infections, particularly those associated with diabetes, are vaccinations. We have ones for influenza and for pneumococcal vaccine, to prevent pneumococcal pneumonia and pneumococcal vaccination. And of course, we hope that there will be a COVID vaccine soon too. Weight loss improves risk of infections and improves glucose control, which also improves risk of infections. Treating other heart disease risk factors makes a difference. Again, if you have lung infections as well as heart disease or heart disease in any infection, they're more likely to have an acute event like a heart attack. So measuring and treating blood pressure, cholesterol, and smoking in addition to obesity is also important. And examining your feet regularly to look for any signs of infection so they can be treated earlier and not get in deep, and so into the bones that require any kind of amputation. To moisturize if dry so that there's less cracking of the skin that allows infection to come in, and also to make sure that a person is wearing good footwear so that they don't injure their foot. So in summary, diabetes increases the risk and worsens outcomes of many infections, including of the skin, the bladder, the bone, and the lung. The risk and outcomes depend in part on what type of diabetes a person has. So they're slightly different in type 1 or type 2, or where they are in the course of their disease. High blood sugars are one of the biggest factors that causes risk and worse outcomes for infections in people with both types of diabetes. Other factors that contribute or add to risk in diabetes are age, obesity, and vascular disease. All treatments that improve blood sugar help prevent or reduce infections with diabetes. Insulin can reduce or improve outcomes from infection beyond just controlling blood sugar, particularly in someone who has a serious infection in the hospital. And prevention is important in diabetes. That includes foot care education with self-inspection and early reporting, and vaccines whenever and wherever they are developed. But research is still needed to answer many questions, and I hope all of you will think about how you might participate in research in ways that would be important to your tribe, your family, your communities as well. Thank you.